Hello, everybody. Good evening, or good morning, or good day from wherever you are streaming. Before we start with the webinar, a few technical informations, and then I will put back the presentation. Today we will have around hour to hour and a half of the webinar about the injectable technique. Here, as you can see on the right side of the screen, you have the chat box through which we are going to communicate. The only my camera and microphone is on, so don't worry, there is no chance that you will accidentally turn on your camera. There is no this kind of the option, so you can sit comfortably and enjoy the webinar. Hello, everybody, from wherever you are. I'm very glad that we have more than 400 registered dentists for today's event. Today we will wait with all the questions until I am finished with the webinar, as there is, we will see how many people will join live. If there is 400 of you, and if you start typing the questions, the presentation will be very interrupted. So please wait with all the questions for after the webinar. And later on, when we are done in the following days, I will try to upload this content to our educational platform. So as I mentioned, today we have, as I see, 190 slides to go through, around 1 hour to 1 hour and a half, depending later on discussion and on your questions. Today's webinar is not sponsored by anybody. I didn't get any money to speak about it, so I will speak honestly about all of the material. In the corner of the screen, you have this we have the name of our educational platform, Injectable Technique, that I will introduce to you and mention few of the I don't have microphone, and mention few of the courses that you can find on our website. I will try to speak slightly louder. Let's start. I think whoever planned to join on time is live with us. The rest we will see the recording or join on the way. All of my lectures, I'm starting with this slide with the word simplicity, because today I will show you the concept of the injectable technique, the one that uses this transparent silicone index, which simplify our work, which simplifies your protocol, and also give you more predictable result. I cannot turn up the volume. Sorry for that. This is the best that we have, so you can turn on your speakers. So I'm like this little girl playing in the sand. I'm fascinated by different branches of dentistry: implant dentistry, ceramic veneer, composite veneer, perio surgery, you name it. But my manual skills are not on the highest level. Like this girl is not, or doesn't have, the same manual skills as some adult. But somebody showed her how to fill the bucket with wet sand, like you can see here in the photo, to reproduce nice predictable morphologies and texture. The same molding or copy pasting technique I will try to show you today, how to get from this clinical situation to this final result in predictable and precise way. Here are some of our cases that we did with the injectable technique: some veneers, some tabletops, some aesthetic cases, some functional cases. If you're interested, how did we do them? Stay with us. Here is one. Another case, some partial veneers, some full veneers, and so on. also combination with crown lengthening. This can be part of multidisciplinary approach, like in this case where we did some gum surgery. We can also elevate the bite, treat dental wear. I'm going to speak later on in the second part of the lecture about dental wear. In the first part, we will speak about veneers. And now just few slides to introduce myself. I'm David Gestakovski. I'm coming from beautiful Croatia. I'm coming from Zagreb, where I'm working, where I'm living, where I studied. I'm working in a small private practice together with my parents and my wife, who is at the moment on the maternity leave with our baby. We also have incorporated lab in our clinic, so I will also speak from the perspective of the lab and the technician and communication with technician. And I'm sending greetings to all of our staff, assistants, students, technicians, and doctors. And always I'm proudly mentioning my dear grandfather and grandmother who started our family tradition many, many years ago and give me strong fundamentals to start dentistry from the youngest age and experimenting during my studies when I actually started with the injectable technique, and big thanks to them. I'm inviting you all to join our Facebook community in this Facebook group, Injectable Technique, Flow Injection, Injection Molding Technique, where you can share your cases, share your comments, your problems, your ideas. The idea is that we learn one from each other. At the moment, we have more than 3,000 dentists who undergo some kind of education or online or hands-on education run by me. Now, we will talk today about the injectable technique or resin composite injection technique or flow injection technique, injection molding technique, all the synonyms for the same concept, as I prefer to call it, not the technique, but the concept, because it is only the idea to think out of the box how to reproduce some morphology with the use of such transparent silicone index, which is on the slides. Now, short introduction about the injectable technique in one slide. First, we need to have properly indicated patients, like the one that you can see in the top left corner of the screen. We impress it or scan it or whatever, and our technician prepare ideal design, which you can see in this yellow printed model. Then we copy this design, no matter if it's analog or digital, with transparent silicone to reproduce transparent silicone index that you can see in the photo. And then intraorally, we use it. Of course, we prepare the channel inside of it, and we inject flowable composite directly in the patient's mouth to reproduce this morphology, which was designed in the lab. So we can say that this is indirect, direct technique with the best from the both worlds, because the whole planning is done indirectly in the lab, guided by technician, by the aesthetic, functional, prosthetical rules, and later on delivered directly in the patient's mouth. And the advantage of this direct technique compared to the classical indirect veneers is that we don't need to have path of the insertion, because when you're injecting, you can inject on multiple aspects of the tooth, also in some undercut areas to reshape the tooth to create better guidance. Okay, I'm doing that. Don't get me wrong. I'm doing also ceramic veneers, classical indirect veneers, or crowns, and everything else. But these techniques have some advantage in some specific indications. Okay. So my story with injectable technique started in 2017 when I made this case. It was 9 years ago, and at that time I was student of 5th year of dental school. Why am I pointing this out? Because, or to give you an idea of the simplicity of the technique, that even the student in Croatia, dental studies last for 6 years. Even student of even not last year of study made case which was good enough for Quintessence International later on to publish it. This was published in 2019 when we have 2 years follow-up. This is 5 years follow-up, and here we also have the photo from the last week from almost 9 years, because in 2 weeks we will have 9 years celebration of those veneers, the first veneers that I made with the injectable technique. They're still in the mouth, they're still in good condition. That's what I'm trying to show you. So more about the injectable technique, except this video or webinar, you can find out in this publication in Quintessence International. Here you have full analog procedure described. And also you have my another publications from the International Journal of Aesthetic Dentistry, the official journal of European Academy of Aesthetic Dentistry, where I describe the full digital procedure of injectable technique with this case that you will see later on in this publication. And I'm very happy to announce that my another case where we treated tooth wear and we raised the bite and did full mouth rehabilitation of worn dentition, both aesthetical and functional approach was delivered by the injectable technique. That case will be also published this year. It was accepted earlier or at the beginning of this year. So sometimes at 2026, hopefully, we will have this another publication with 3 years follow-up. I'm always publishing, sorry. I'm always publishing and showing the cases that I have multiple years follow-up to show. Now, as I mentioned, I'm standing in front of the Injectable Technique educational platform, and today I will show you a few things that you can find on our educational platform as kind of the promotion, because this month we are celebrating 6th birthday. So because 6 years ago we started with our first course, and so far more than 15,000 dentists undergo some kind of education, if it was online or on-site hands-on. So on this site, www.injectabletechnique.hr, HR stands for Croatia or Hrvatska in Croatian language, you have different courses and also different free educational stuff that you can find. So on top right part, you have different sections. We will speak about courses later on, but you also have the free education. When you click it, you have several different options, and in this publication sector, you can find both of the articles that I mentioned previously. You can download them for free and read in peace of your home and learn more about the injectable technique. You also have some tutorials, some clinical videos of full procedure of production of transparent silicone index or the mock-up. Today I'm not going to show you those videos because they're uploaded, so later on you can all go through those videos. And in the same way, today's webinar will be published sometime this or next week over there on our educational platform. Okay, go on. Also over there, you have few case reports with few cases that I did many years ago. Actually, I think all of them are from 2019 or 20, and all of those veneers are still in place. Later on, I will speak about the courses that we offer on this site. For the moment, just to shortly speak a little bit about us, we are holding around 40 courses per year. Some of them are online, some of them are hands-on. Majority of those are in Croatia, but I also travel abroad, mostly to Germany, Poland, and some other European countries. Later on, I will tell you where you can find all of the announcements of all of the courses, and I strongly recommend you to follow some of our courses before starting your first case, because all that I'm going to show you today seems very easy, but for me it is also very easy to look ice skating on the Olympics, but it is artistic ice skating, but in reality it is not so simple. And on our courses I will always try to to encourage you to try everything and do all of the mistakes on the models with me, and to be prepared for your first patient. And I'm also proudly mentioning that most of the European and world lectures about injectable technique passed some kind of my education in early 2020s, 21 and 23, as I was one of the pioneers in this technique, started even before GC launched great materials for this technique. Now, you can take the photo of this slide. First, we will start with the short protocol of the injectable technique. We'll be focused on the simple case of PEG lateral, the lateral incisor, the one that you can see in the photo. This is the case from International Journal of Aesthetic Dentistry. You can see, or you can recapitulate today's knowledge in this article. We start with the etching of the enamel. Oops, sorry. We need to isolate neighboring teeth not to over etch them. Then we rinse and dry, and later on we continue with the isolation. Back in the days when I was much slower, I used dental cord. Nowadays, I don't use it very often. You can use it for the isolation before placing the adhesive. Okay, for the adhesion, I'm using G Premium Bond. By the way, as I mentioned, the webinar is not sponsored by anybody, but all of my courses are covered by the GC, and I'm sending greetings to all of my dear GC friends from all around Europe who are helping in organization of our courses. Today, all of the materials that I'm going to mention, I'm actually using them in my real practice. And G Premium Bond is my bond of choice, not only for the veneers, but for also different restorative protocols. A few words about the G Premium Bond, the bond of latest generation, single bottle bond. When you apply it, rub it for 10 seconds in the surface, you airspray on for 5 seconds on maximum power of the booster of the compressed air, and you let it welt. You light cure it for 10 seconds by the manufacturer, by the instruction of the manufacturer. And what is crucial about this material is that after light curing, it stays in super thin layer of 3 to 5 microns, which is great for our non-prep restorations. Then we start with the injection part. We inject until everything is properly filled. We do short polymerization, remove the excess on the margins of transparent silicone index, and do final light curing, which I always prolong. As you know, the bigger distance from the curing lamp to the composite, the lower energy of the polymerization lamp you will have. Oops, sorry. This is after light curing of the composite. We start with finishing and polishing. I start by removing the excess with scalpel blade number 12, the curvy one. Okay. You can protect the neighboring teeth with the metal matrix. Then with this kind of burr, I polish the cervical areas. Okay, because you will always have small step on the cervical area. With some pre-polisher, I'm using EVE polishing tools, EVE Universal, the one that you can see in the slide. And for the final polishing, I use EVE Spiral, but the green one. And those we also use on our hands-on courses. Regarding polishing of the interproximal surfaces, I'm using Epitex blue and green. These are great stripes, which are not going to remove the composite, but they're going to polish it. Okay. If you need to remove it, then use metal stripe. Okay. But if you need only to polish Epitex, you have blue, green, orange, and white. The coarse, medium, fine, and extra fine for this purpose. For the final polishing till the high gloss, I use Spiral from EVE Twist, and then for the final, I use the polisher paste in combination with cotton buffer, the one that you can see in the photo. And this is the final result that we can get. Okay, it is always the hardest to do only single veneer. So for your first case, I strongly recommend the case with 6 veneers, because it is much easier to get homogenic appearance if you do from canine to canine than if you do only one tooth, especially one central. But as you can see, if you have good, skillful technician, and if you work with a lot of magnification, if you leave yourself enough time, you can mimic and you can do even one veneer and try to make it as natural as possible, and the same with the same shade, with the same shape, gloss compared to the neighboring teeth. In this case, we of course first bleach the teeth. As you can see, there is difference in the shade. This is from 12 o'clock point of view. You can see the left one and the right one look pretty much the same. So once again, here you have the full clinical protocol in one photo, and you can see the full case in this article from International Journal of Aesthetic Dentistry, which you can download on our educational stage. Now, to give you wider idea about the full protocol of the injectable technique, not only clinical one, I will go through the topics from our online masterclass. We have 2 different online masterclass, the aesthetical one, which is based on the veneers, and the functional one, which is more focused on the raising of the bite, function, individualization of the articulator, raising of the bite, and of course, composite tabletops. So here in this section, in the courses, you have both online courses and hands-on courses. In the online course section, you have those 2 courses, which are also included in some kind of the packages, 3-in-1, 2-in-1, or single courses, depending on your wishes and desires. At the moment, as we have special promotion, because we have 6th birthday celebration, so you can get some discount this and next week. And we also have translated them in various languages: Croatian, Italian, English, and Spanish. And I will also invite you to our most comprehensive hands-on course so far, which will be held in September in Zagreb. Later on, I will speak about this course, but we will have 2 full hands-on days on the models, 16 hours of the practice, and all of the participants will get 14 hours of the pre-recorded theory to prepare themselves for the course. Here you have the QR code who is interested, and we will shortly continue with our slide. Save the date for the September, 2 days, Friday and Saturday, and have in mind that the part of this course is actually our online masterclass. There is no need to register for both of the courses. So in this course, you also have our online education, and you will try everything on the models. So let's start with some topics from our masterclass to speak more about the injectable technique. For the introduction, have in mind that not all flowable composite materials that we can find on the market are suitable for every clinical situation. Okay, maybe some of you are a little bit skeptical about using flowable composites for the veneers, and today I will try to break this stigma. About the materials, as I mentioned, all of the materials that I'm, or most of the materials that I'm using on my courses are from the GC. And the reason is that because I use them also before starting the courses, because in my opinion, for the injectable technique, the GC have the best possible materials. As you can see, here we have various transparent silicone indexes. The one on the left side is from the Exaclear, the one that I'm using in my everyday practice. And I'm using it because it is the clearest one. Compared to the one on the right side where you don't see anything, the one on the left side gives you much more comfort while working, because you have everything under the control. And if something happens, you can react because you can see what is going on inside actually. The one in the middle is Memozil, the one that I used back in the days before Exacclear was registered in Croatia. Okay, so nowadays when I have the Exacclear in Croatia, I'm using the one on the left side. Later on, I will also speak about the flowable composite of my choice, and that is actually, I don't know if I have slides, so I'm going to mention now, that is Genial Universal Injectable, the one that you can see in this photo. And since 2019, when it was released and showed on the IDS, all of my cases are done with it because it can be polished perfectly. Okay, so here you can see one case done with the Genial Universal Injectable, single shaded, so only one shade per veneer. And look at the gloss. This is without any glaze. Okay, this is only purely nicely prepared case with great morphology. I integrated a lot of texture inside in my clinical protocol of finishing, and I polished it properly with all sequence to get this high gloss. And this is my favorite part of our hands-on course, when I see the face of the participants who start polishing the material and the result that they are getting after polishing. I'm working with various material from GC and from other brands. As you know, we all work with different brands. I'm not going to lie to you. I have also the 3Ms, the Chafus, Ivoclar, and so on in my clinic. But no other material I can polish as nicely as Genial Universal Injectable, the one that you can see in the photos. Okay. We're speaking about case selection. When speaking about case selection, have in mind that all of the cases that I'm showing are purely additive. So we're adding materials on top of the teeth. Okay, we're not preparing the teeth to get some space, but we're just adding. So if the teeth are rotated, protruded, too big, and so on, those are not indication for the injectable technique. Okay, or maybe we need to do some kind of pre-prosthetical preparement like the ortho or so on. Okay, don't try to push the limit. I'm general dentist, and I'm with master in dental implantology, and I'm doing surgery, removing of the calculus, endo treatments, veneers, aesthetics, and so on. I'm not only doing injectable technique veneers, okay, but I'm seeing like five to six patients, new patients per week coming for this treatment, and on average 50% of the patients who come, I say, sorry, you're not indicated. Okay, so don't try to push the limits of the technique. And this technique is minimally invasive. It's not non-invasive. It is non-prep. We don't prepare the teeth, but the moment we etch and bond, we did some minimally invasiveness on the tooth. It's not as invasive as, for example, for the ceramic veneer, when you need to prepare 0.3 or 0.6 for the minimal thickness of the material. Here you don't have the minimal thickness of the material because you're going to end on 0. something thickness, but still it is minimally invasive. About case selection, some small diastemas, peg lateral that I showed you. Worn teeth can be treated, but be careful about the function. Something caused this wear, and we need to take care of the wear before finishing with the aesthetical outcome in the anterior region. Some misalignment of the teeth, like for example here, palatally positioned teeth, like in this case, and so on and so on. Once again, do not push the limits. You can see the top photos. From the top photos, I could not reach to the bottom photo without this middle phase, which was after the ortho treatment. In many cases, we start with the ortho to realign the teeth in the proper or better position, and then in this better position, we reshape the teeth with the injectable technique. The planning is very important. The impressions, taking the intraoral, extraoral photos, videos, doing DSDs, and so on. You can do everything fully analog, or fully digital or hybrid way, which I prefer, taking the analog impression, taking the phase bow. On our functional courses, we are taking the phase bow, we are describing individualization of the articulator, we are registering centric relation, and so on and so on. And when I have all those informations in my analog articulator, we scan it and we continue with digital design. The biggest advantage of the injectable technique compared to some other techniques is the chance that you can try the mock-up as the strongest tool in your protocol. First, we need to have the wax up done by our technician, no matter if it's analog or digital, okay? So both work fine, but what is the biggest advantage is the consistency in the morphology in between design, in between the mock-up and the final result. This is my colleague who was patient. And by the way, about the indication, 25% of my patients are dentists and their kids. Why? Because it is less invasive compared to some other indirect treatments. Anyhow, let's continue with the presentation. This is the wax up. This is the mock-up. In the mock-up, you check phonics, aesthetics, function, everything which is crucial for your final treatment. And here we have the final veneers. So check the consistency in the morphology. Okay, so I don't start with my veneers before we check the mock-up, before the patient like the mock-up. Just then we move on and do our veneers. It is important to know how to prepare transparent silicone index properly. Today we don't have enough time to speak it in detail, but transparent silicone index is impression of design, no matter if it's analog or digital, with transparent silicone, with the Exaclear that I mentioned previously. I drill one hole on the incisal edge or occlusal surface. And as I mentioned, I'm using the Nemozil for two main reasons. One is precision, so it will capture all details in the surface. And the another one is the transparency, which I already spoke about. So all of the transparent silicones on the market have high light transmittance, but the haze, how much you can see through the material, is the lowest in the Exaclear. And that's why it is my material of choice. Be careful, it is very, it's not so handy to manipulate with the transparent silicone, and this is always the trickiest part of the hands-on when the participants are doing the transparent silicones by themselves, because there are plenty of things that you need to think about, and you need to be quite fast because the manipulation time of the material is quite short. So so everything needs to go fast and smooth. About the intraoral protocol, I already showed you this case. And about finishing and polishing, this is a very crucial part of your treatment. When you're almost done and you think, okay, now I just need to polish it, trust me, you have extra 30 or 60 minutes until you polish all the margins and polish the whole surface properly till the high gloss. Back in the days, I used this kind of the spirals from the 3M Softflex. Nowadays, I'm using abot twist because I found them much more handy and better for my composite, for the Genial Universal Injectable. About timing and pricing, have in mind that this is simple technique, but it is going to, you will need a lot of time to practice it. To perform it. So at least 45 to 60 minutes per veneer leave in your schedule for your first case, which leave us to pricing, which need to be according to your timing and your knowledge and your skills. Probably you will get some hands-on before starting your first case. So you will invest in your knowledge, you will invest a lot of time, so you need to charge accordingly. As you can see that we have people from all around the world with all different, not society, but all different pricing range of the same dental dental price list in different countries. I'm not going to specifically speak about the pricing, because my price don't have anything to do with your price in Germany, in Macedonia, in US, in Japan, and so on. But I'm going to speak in the ratio. I charge double compared to the freehand bonding and half price compared to my ceramic veneer, because at the end of the day, I put the same effort to the case, same knowledge, same precision, same timing, like for ceramic veneer. The difference is in the technician part. So this is how you can calculate your prices. In my case, I have ceramic veneers, then half price I have injectable technique, then half price I have freehand bonding. In our second webinar of aesthetical masterclass, which is in total lasting for 8 hours. So in the second webinar, we show different modifications of the technique. So of course, you can combine various shades, you can do polychromatic veneers, you can do some tips and tricks to make your life easier and faster. And I'm showing this in the case, in the serial of clinical cases. These are from, for example, space holders, which were explained in my Quintessence International publication. And here you can see some. Here you can see some polychromatic veneers on 20 months follow-up. And actually, this guy was just on Tuesday. He was in my office, and those veneers are now 7 years old. After 7 years, I can see that they are not as good as they were, for example, here on 1.5-year follow-up, but they're still in good condition. They're still in the mouth. But regarding longevity, I'll always tell my patients that they will be satisfied for 5 years with those veneers if they properly clean it. Here is one case that you can see in our masterclass, and that we are doing the simulation of this in our hands-on course, where we are combining both layering technique and injectable technique. There is no restriction of using multiple shades, multiple opacities in combination with injectable technique, but you need to pay attention to some details. Here you have one close-up, or maybe few close-up photos of my cases done with the injectable technique. And have in mind that this was not done by me, by Heidelman's spatula with brushes and so on. This is actually my technician's design, which I just copied with transparent silicone index. Are the old cavities or old fillings contraindications for our composite veneers? Of course not. And here you can see the old composite veneers on the top with the new one that I redo. The injectable technique give us opportunity to reproduce nice curvatures, nice convexities of teeth which have a natural appearance. And after you add a little bit more details in the texture and polish till the high gloss, it can look magnificent, as you can see in this photo. The function is very important. Now we don't have much time to speak about the control of the function, but have in mind that all of my patients I always protect with a Michigan splint. So this is mandatory for me for all of the composite veneers, tabletops, simple aesthetic or more complex functional cases. There are various tips and tricks how to save time, and we're also comparing analog and digital. Most of the time nowadays I am printing my models, but there is no better option. There are just some few differences in the protocol which makes your life easier, but have in mind that digital dentistry is not more precise compared to the analog still today. Okay, analog have its own place in dentistry. At the end of the day, our patient is analog patient. Okay, so if you're scanning, have in mind that most probably you are less precise than if you're taking analog impressions, no matter what the companies will say. We're comparing all of those, and I'm trying to show you all of the mistakes that I did. for today's short version of the webinar. Few most important mistakes that can happen is air trapping the bubbles inside of the composite. To be honest, in my first case on 6 veneers, I got bubbles on 3 out of 6 veneers. Nowadays, I don't get the bubbles anymore because I learned how they appear, how to prevent them, how to protect them, how to protect myself from staying in the composite. But have in mind that this can happen. Wrinkly Teflon is also not good for your veneers because it will deform your transparent silicone index. Uncontrolled excess can be the nightmare. So have in mind that you need to control the excess of the flowable perfectly. When you inject, have in mind that the material will spread and you need to keep it under the control. If you control it, everything will be fine. If you don't have it under control, then you will have the problem. And the bleeding can be, of course, the nightmare if the patient doesn't have proper oral hygiene and gingivitis. You need to place the Teflon around the teeth. The bleeding will start and the whole appointment will be ruined. So be careful about that. Here are some of our master cases from the masterclass. You can see a lot of the details in the texture. You already saw this close-up photo, or this one, or this one, and some functional cases. Okay. So all of the topics that I mentioned you can find in our online webinar. Mohammed, we are going to answer all of the questions after the full program. So in our online education composite veneers, you have, of course, much more in detail explained all of the topics that I mentioned today. And this is actually the first part of our hands-on course of Saturday's program that will be on 19th of September in Zagreb. And on Friday, on the first day, we have functional program where we speak about tabletops, function, and so on. And now I will concentrate more in the second part of the webinar. I will concentrate more on the functional aspects of the injectable technique. For those of you who are interested in our hands-on course, here you can take the photo of the program and you can find it on www.injectabletechnique.hr. Whoever register, after registration, you get the access to the 8 hours online pre-recorded course with theoretical part, and on site we do only practical part. The feedback from the participants is great about this concept because everybody can watch in peace the whole theoretical part, write notes, check everything, and then we have full day for the practical part. And later on, after practical part, after hands-on, if you will still have some questions, you can always go back and rewatch the theoretical part. So in theory, in one day, we included 16 hours of educational program. And now let's speak about dental wear, about full mouth rehabilitation with the injectable technique, about the production of composite tabletops. Have in mind that tabletops are aesthetically less demanding compared to the veneers, but they're technically more sensitive. The technique is technically or manually more sensitive, and we need to pay attention to more details. This is one case from young girl. By young, I mean 28 years of age, and you can see the amount of dental wear that she got on her upper and lower teeth. Okay, this is our master case from the webinar. And before we start, I will again show you the full clinical procedure on distal teeth. Actually, just here with me, I have the same model like from this slide. So we need to have prepared transparent silicone index based on ideal design. We start by isolating the teeth with the rubber dam, as this is crucial for me in distal areas, in posterior teeth. I included this part in my hands-on as well, so whoever joined our our functional program hands-on course, we'll have chance to work with the ISO dam, the same rubber dam that you can see in this photo, who is also sponsoring our hands-on courses, the same as EVE company, which gives us polishing tools, polishing rubbers and spirals. So you have chance to do with all the materials that I'm showing and that I'm using in my real practice. After we isolate properly all of the teeth, we start by isolation the every second tooth with the Teflon. You don't need to do one tooth at a time. You can do multiple teeth simultaneously, okay? We etch every second tooth, rinse and dry. We apply the bond, again, G Premium bond as mentioned previously. We light cure, okay? And then we place the transparent silicone index and we start with the injection. This is also old case, many years ago, still in good condition. Here you will see one of my favorite photos from this presentation. Come on, where is it? Here. You can see how nice transition we got from the composite surface, composite tabletop, or one lay, or however we are going to call it, to the actual tooth. To achieve this, you need to have precise impression, precise model or scan. You need to have precise design. Later on, precise, again, model or print. You need to properly apply Exactclear and copy and transfer it in your transparent silicone index, and yet have good stability of the index intraorally while you're applying. So many steps that can go wrong, but if everything goes smoothly, if everything is nice, precise, and as it should be, you will get good result. As you can see, the expiring date on this tube is 2024, so this is from, I think, 2022 case, something like that. Come on. And here you can see the before and after. In this segment, I'm always trying to do segmentally one side of the one jaw, another side frontal, and so on and so on. On some of my cases, you will see also full arch isolation, but nowadays, because of the simplicity, I prefer to do in segments like here, distal segments, premolars and molars on one side, then on the other side, and then frontal teeth at the end. Checking of the bite. And yes, so the rest of the full protocol from the introduction to the planning and so on, I'm going again to explain through the topics in our online functional program course. This course is orientated to the functional planning, raising of the bite, and at the end, final delivery of composite tabletops. But the same planning and idea can be also done for classical ceramic tabletops, crowns, bridges, implant dentistry, and so on. So in the introductional part, we go, through different literature papers. And here is the most important, I would say, to raise the awareness of dental wear and the indication of the dental wear. And in this article, they studied different populations from all around the world, and they found out that pathological tooth wear can be found in 30% of young adults and adolescents, okay? So this is not some granny or grandpa or grandma. These are actually kids, okay, which have pathological tooth wear, which after longer period of time will cause the same wear as I showed you in first slide of dental wear section of the webinar. So we speak about dental wear. As you know, there are several different causes of the dental wear: erosion, abrasion, attrition, abstraction, and so on. Rarely they work alone. Most of the time they integrate one with each other, but we need to know the protocol for all of them or treating all of them. And when speaking about different treatment option of dental wear, I was actually shocked when I realized that in the literature, in different meta-analysis and so on, there is no one exact best treatment option for treating tooth wear. When they compared indirect and direct restorations, like ceramic and composite, there is no meta-analysis that will claim the one is better. Okay, they have certain advantages, both of them, but still in official dental literature on the PubMed, you won't find the claim that one is better than the other. So our direct restoration have one or can be one of the potential options. In this Francesca Vailati's clinical evaluation of 6 years survival rate was 97.3, which is very good with a 2.7 failure rate. On average, we can find around 5% failure rate in around 5 years. And I tell patients that they will be satisfied with my composite restoration for at least 5 years. So in this period of time, when you do full mouth cases, there is chance that you will have some chipping, and by the average on the average 1 out of 20 restoration, you can expect some kind of small chipping, which later on you will easily repair because you're going to repair it with composite. Okay, about material selection, I already mentioned that transparent silicone is done by the Exaclear, and I'm using Genial Universal Injectable for all of my injectable technique cases for the aesthetical reason, because it can be polished like crazy, as you saw, but it also have great flexor strength, higher compared to some paste composite, and check this, it has better wear resistance compared to some other paste composites. The composite is going to wear sooner or later, of course, but if we can use the material that is going to wear less compared to the paste, to some other composite, of course we're going to use this one. And Genial Universal Injectable is the one. I can confirm you from my 2, 3, 4 years follow-up of using it in raising of the bite. So all of the teeth are restored fully in the composite, and they're working quite good. There are various materials that we can register bite, register centric relation. That's what we're covering in detail in our full program. Now we don't have time about it, but this was just to announce the importance of the functional analysis, to take the face bow, to mount model in the articulator, because only with this information you can predictably design future contact in the new vertical dimension. Because with the face bow, we are mounting the upper model in correct position of the face bow, and the correct position in the articulator, and correct position in the articulator determine the radius where the pure rotation is happening, which you can see in this photo. So if you don't have the model in correct position in the articulator, when raising the bite, you will lose the pure position of the mandible. And when mounting the lower model, we're always using centric relation position as the most passive, repeatable, and stable position of the lower jaw. How we do it, we demonstrate on our course on Friday, 18th of September in Zagreb. You can join us and learn about the articulator individualization, protrusional registers, lateral protrusional registers. We explained the Manet's angle, the angle of the condyle pad, and so on and so on. Function always go very, very tight with the aesthetics, and there is no aesthetics without function. So actually our Both of our courses are interlapping one with each other. Here we are explaining the aesthetical analysis in the DSD software Smile 5, but whichever you're using, this is great. I'm using it mostly for the idea of the future incisal edge and communication with my technician, sometimes for planning the surgery, like in this case, following all of those lines. Now we don't have time to explain every of those in the details, but technically in perfect aesthetic and functional case, we need to evaluate all of those parameters of the smiles. Sometimes we will need to do some treatments, like I mentioned previously, ortho treatment or surgical treatment. Why is that important? Because the gum line is also determining the perfect, or it's determining the final aesthetical outcome. If we don't have proper gum line, our aesthetic result will be compromised. Sometimes rarely I'm doing simple gingivectomy. Most of the time we are doing with raising the flap, osteotomy, and real surgical crown lengthening. Whoever wants to learn more about it, in our functional program, we are explaining this part in detail, as well as, for example, in this case, you can see the importance of the gingival architecture. Those are not composite veneers. These are ceramic veneers, ceramic crowns. On the lower we did only the ortho and one implant, but to give you the idea of the importance of the gum line, here you can see how big transition can be done also in this pink part of the aesthetics. Regarding wax up and occlusal design, it is slightly different compared to the veneers, because we are here mostly orientated on the elevating the bite, so we're staying more on the occlusal table of the tooth. Here you can see, and I usually am showing a lot of real designs from the software, Exocad, etc., various softwares that my technician is using. Regarding design of the occlusion, we are trying to have the tripoidization of the contacts on the right is utopia. In real life, if we can achieve the contacts on the peak of the bearing cusp, so-called B contacts, the one that are circled, we will be super fine with stable occlusion on both sides in the distal teeth and protrusion and lateral protrusion in the anteriors. This is what should we be looking for. This is, for example, one example of design in the lower jaw when raising the bite. As you can see, the wisdom tooth is not covered. I'm rarely doing wisdom teeth. They are a great anchorage for the clamp. Here you can see it from different angulation, the amount of rebuilt teeth. At the moment, just next week, I have two of similar cases that we are going to treat: full lower, full upper, or combination with some bridges, with some implants, and so on. Here you can see the case that I showed you before, or the initial, and after we made the wax up, and later on you will see also the final intraoral result. Of course, never skip the mock-up, because the mock-up is super useful tool to evaluate your plan and also to show to the patient the final result. Transparent silicone index is going to be cut or adapted slightly different compared to the veneer cases, because the design of the tabletop is slightly different. Here you can see the sample of the transparent silicone cut in half together with the model, to give you the idea of the future tabletop and where the tabletop is sitting on top of the tooth. The clinical procedure I already showed you, so I'm not going to waste more of your time about the clinical procedure. And here you can see one before and after case treated with the injectable technique. On the left side, you can see the aesthetical part. We did crown lengthening, we did veneers. On the right side, you can see the functional part with the worn out teeth that we rebuilt with composite tabletops, and this is the case which now have more than 3 years, 3.5 or 4 years follow-up, and this one will be published in International Journal of Aesthetic Dentistry. So whoever wants to learn more about it, you can also subscribe to the International Journal of Aesthetic Dentistry, great journal where great authors are showing their work, and you can learn a lot from it. So if you're interested in those topics that I showed you and I spoke shortly in a few short phrases about the topic, you can find out more on www.injectabletechnique.hr, the functional program, which is also the first part of our first course in Zagreb on 18th of September. On Friday, we are having the functional program where you will be work with the rubber dam. We are going to work with the face bow, with the centric relation, and of course every participant is preparing their own transparent silicone index, which is very important, because if you think your technician is going to do it, that's great, but most probably your technician has never heard for the injectable technique and transparent silicone index, and he or she will not be ready to prepare such index. So you need to know the also laboratory basics about those things. So we are doing it and showing on our courses. We are making also the putty silicone indexes for the mock-up. We are trying the mock-up, and of course we are doing the injectable composite tabletops on Friday, and veneers with various modifications on Saturday, such as layering technique, cut back, shade mixing, and so on and so on. So if you want to follow more about my work, you can find it on Facebook page Injectable Technique by David Gestakovsky. On Instagram, you can find it under Injectable Technique Gestakovsky. These are my my professional pages and profiles. On my private profile, you won't find any dental content, so you don't need to add me on my private accounts. Over there you can only find my dog. Here you have our official email, injectable.technique@gmail.com. I'm inviting you to join our Facebook community in this group, and I hope that we will see each other on some of the events. So far we had more than 250 international events with participants from all around the world. More than 15,000 passed through it. On our educational platform, in the courses, you have courses which are organized by me, and you also have hands-on schedule, where you have the schedule of all international courses. In the April, we have the course in Munich. In May, we have course in Stuttgart. I strongly recommend you to come and visit us there. And if you want to have the full story with 30 hours of education, 2 online days and 2 hands-on days, once again, see you in Zagreb, in beautiful Zagreb, for comprehensive course on 18th and 19th of the September. Once again, during this and next week, we will have some discount because of the 6th birthday of our educational company. If you will have any questions now, feel free to write it down. I'm going to put some video to give you more idea how our hands-on courses look like. And have in mind that on our online courses, if you pick some packages, including more courses, you get bigger discount and you get longer access to the educational content. Now you can put down the volume, because I'm going to play the video, which is quite loud. And in the meantime, feel free to ask in the comment section, and later on after the video, I will answer to your questions. Okay, so I'm going to start answering from the last till the first question. Mohammed had a question about multiple restorations or cavities. 4. He wrote 5. Yes, you can combine various techniques like the palatal shell and so on, but compared to the actual palatal shell technique, I slightly modify the technique. I don't do actual palatal shell. I use palatal shell index for building up the core of the tooth. This is actually what we are practicing also on the hands-on, as this is something that I'm practicing quite oftenly in my clinic when I'm lacking the support to avoid, and I'm building up the dentinal core to avoid grayshness of the restoration. Dalia, I have a question. If you're already having restoration on the teeth that you want to inject, do you first remove and then place the new composite? That's totally depends on the case, okay? If the restorations are new, if they're good, you can bond on top of them if you have enough existing enamel. If they're bad, of course, you're going to remove them. You can remove them before the impression or after and before injection. So if we have 5 cases, probably we'll have 5 different approaches. Is the course in Zagreb in English or only in Croatian language? Of course, this one is in English. There is some more basic course in Croatian, and the description is in Croatian language, but the one that is described in English, this one will be in English language. And this is also including some Croatian traditional dinner and stuff like that. So whoever wants to explore a little bit of Zagreb, trust me, it's beautiful. This is great opportunity. What type of resin do you use for the printed wax up? I'm not printing myself. My technician is printing, so I cannot answer this question. But what is important that those models are properly cleaned, okay? So they're not sticky. Otherwise, your silicone is going to have chemical reaction with it. Which 3D printer for models can you recommend? Once again, my technician, outsourced technician is printing it. I don't own myself 3D printer. Dalia, I have a great question, which I think all of you will have this idea about potential chipping and breaking of the composite. I'm going to read out the question because the participants who are going to look at the recording won't have the chat box. Is the GC universal injectable flow? And this is not Genial universal injectable flow. You have Genial universal injectable flow and Genial universal injectable. Now, Genial universal flow and Genial universal injectable. This is the newer material, Genial universal injectable. Predictable in time for parafunctional patients. For parafunctional patients, yes, but not for parafunctions. So with your design, you need to take care of parafunction. But everything can break. My father had the case of metal porcelain fused to metal bridge where metal broke just today. So everything can break under improper functional movements. If you have some functional interference and if you don't have proper functional guidance, yes, it will break. The study showed that chance of chipping is more related to the parafunction than to the material selection. But if you have proper design, taking care of parafunctional movements and parafunctional interference, and you protect your veneers or tabletops with the splint, you won't have chipping. Does the composite break under strong forces? Yes and no. If we claim strong forces for chewing, it's not going to break. If we consider it opening the beer bottles, it can break. And I know this sounds silly, but my best man from my wedding broke his natural tooth, second molar, by opening the beer bottle like this. So yes, only the universe and the human stupidity doesn't have any barrier. And for the anterior side, when we want to solve the anterior guidance, will the composite chip, not if it's properly designed, if you have smooth transition, and this is what we teach on our courses, it actually works quite great. In case of multiple teeth restoration, silicone tray have barriers in between the teeth for proximal surfaces? No, because I have like this. I have it like this and then captured with transparent silicone. But there are few different tips how you can prevent material overflow and protect those areas. But you need to be able to floss and to have strong contact points in between the teeth. If I inject multiple teeth, how do we make sure the interproximal parts are separated properly? You use Teflon tape for the isolation. Can we use this technique in case? So we answer this part. Okay. We have some extra questions, so now let's find them out. Also, do you have some specific requests for the wax up, like leave some areas for a better sitting on the exact index or some space at the gingival area? Yes, so the communication with the technician is mandatory. Technician need to technician need to prepare the wax up as nice, natural as possible. I do transparent silicone myself because if something goes wrong, I want to see it, I want to understand it. You said that you put the patients on a Michelin splint. Yes. Do you adapt it after at some certain time? No. And also, do you start case with an ATM splint before injection? No. Because with injectable technique, I'm going to raise the bite for like 1 to 3 millimeters. I'm not going to raise the bite for, I don't know, 2 centimeters. And for those small adjustments in the height, like up to 3-4 millimeters, the splint is not required. And by the way, when you use splint for new height, trust me, there is no chance that you will do restoration exactly in this height. Okay. You will always be or a little bit lower or a little bit higher. So I'm never doing reprogrammation with a splint. I just go for it. I try everything in the mock-up. In the provisional stage, we test everything and we do the adaptation. But the splint is like that. My mentors taught me it's not necessary. Okay, how to deal with tight contact points with bruxism patient? Good question. Sometimes it's impossible to remove excess composite from the interproximal surface neatly because it's so tight. No, it's always possible to remove the composite. If you have tight contact, you don't have any composite excess here. The proper design of your tabletop will prevent fluctuation of flowable on adjacent teeth. Okay, but in case of tight contact, it can be problematic to place the Teflon. In such cases, I put metal matrix in between the teeth to relax the teeth or to open the contact point in between because of the movability inside of the periodontium ligament, and then I place the Teflon inside. But to prevent fluctuation for for prevention, you need to have proper design and copy everything properly with transparent silicon. If you don't have proper design, then then it can be messy, and then it can be problematic. That's what I said. It can look easy, but there are a lot of things that you can mess up. So once again, please follow some of courses before experimenting, because I made all of those mistakes at the time I started. There was no materials, no courses, not anything. I did all of the mistakes. Now I want to share them with you, and I want you to try it, to feel it, to understand it. Do you use polishing paste? Yes. Which one? Yes, I use the polisher paste from GC. After doing any one of your injectable case, do you make for them any night guard for term of time to adapt with such new demand? Ariane, I showed, yes, I do. I do Michigan Sprint for all of my cases. How can I avoid having visible print lines on 3D printed models? You can polish it. It's better to polish the model than to polish the composite. So half of the job is the technician's skill. No, it's most of the job, technician's skill, but it is also your skill not to make proper indication, to try everything, but without good technician, you cannot get good result. This is good, Anna, that you mentioned. I will cite my mentor, shit in, shit out. So if your technician don't create perfect morphology, you cannot get perfect veneers. The cases that I showed you is because my technician get great, made great morphology and great texture, okay? So you need to find skillful technician. Can I use universal flow rather than injectable flow? You can use whichever material you want, but I'm using Genial Universal Injectable. So technique is not limited to some specific material, but I'm showing you which is the best. And one last question. In case of multi-layer technique, when we want to do characterization to the teeth, okay, yes, we incorporate the injection by having the last layer, of course, which would normally be enamel. Yes, on top of everything we have built. Also, regard, Dalia, you put the question mark on end of this sentence, but this actually can be statement. This is everything that you mentioned is correct. Also, regarding the color, how does the composite look in the thicker layer? Plastic, fake. The thinner is better, like any other composite. No composite in thick layer look good. Does it turn more opaque so the tooth will become too saturated gray in monoshades? Yes and no. If you have a background of the tooth, it won't look too shade, but it will look fake. I don't like thick veneers. I like thin veneers. The thinner look better. Some of the veneers that I showed you were 0.02 millimeters in thickness on the thinnest part. Of course, I don't encourage you to make 0.0 something thickness, but 0.23 is just fine. Thanks a lot for this webinar. That's really amazing. Thank you, Mohammed. Thank you a lot. How you know you inject enough of the flowable? You see it. If you use Exacclear, you see. If you don't use Exacclear, it's pure luck. So you have everything under the control of the eye if you're using really transparent silicone like this one. Check this out. So yeah. Okay, guys, thank you very much for joining. Thank you very much for your questions. That was it for today. Once again, whoever wants to practice everything that I can and I usually teach in various countries, this is the most comprehensive hands-on course. If you want to see some shorter version, like one day courses with one topic, you can find it on our educational platform in hands-on schedule in Germany, Poland, Czech Republic, and so on and so on. Thank you very much for joining us today. This will be published online, and hope to see you sometimes somewhere on some Congress event or some other gathering. Bye-bye, guys.